Live streaming is on.
So, good evening, everyone, and thank you very much for joining us at tonight's Exploring the Future of Musculoskeletal Research. And I have with me some members of the Musculoskeletal Biomedical Research Centre team who will be speaking today, giving you a wave there. So my name is Kate Frost. I am the head of Patient and Public Involvement and Engagement for Nottingham Biomedical Research Centre. And I will be what you'll call your host for today. I just wanted to introduce you to the concept of the Research Lounge. So essentially, the Research Lounge is a space where we can discuss openly and transparently topics of interest for yourselves, for patients and the public, and for our clinicians and academics. So today we're coming together to share information and to have exploratory conversations about the future of musculoskeletal research at the Nottingham Biomedical Research Centre. We have been joined by Professor John Gladman, who I'm going to pass over to in just a second. But first, I wanted to just highlight that you can post any questions you may have in the discussion box, which should be on the right-hand side of your screen. And the mantra we always go with is that no question is a silly question. So please do post anything in there, and I will facilitate those questions to all of our speakers. I'd also like to mention that if you are having any technical difficulties, then please go to the technical support help page, and this will direct you to our technical team who are supporting the event today. I just want to thank you again for taking the time out of your evening to attend this evening's event. It's fantastic that you're giving your time to contribute, and I really do hope that you enjoy the session today. So with that in mind, I will pass over to Professor John Gladman, who is the theme lead for the Nottingham Biomedical Research Centre Musculoskeletal theme, who is going to give an overview of the theme in Nottingham and Derbyshire. So John, I'll pass over to yourself if that's okay. Oh, John, I think you're on mute.
Right.
There you go.
Hopefully you can hear me.
Yeah, can see everything fine, John, and can hear you now.
Excellent, excellent, excellent. Well, thank you, Kate, for arranging this. Thank you, the team. Thank you, everybody, for pitching up. So this is me, John Gladman, the lead of... We're going to use this phrase MSK quite a bit because musculoskeletal is quite difficult to say without your teeth falling out. It's one of the abbreviations we'll try to avoid, but it might be helpful. So I'm by background an academic and a geriatrician. But what I want to do in this very brief starter here is just tell you what musculoskeletal research means, particularly for us here in Nottingham and Derby, because it's a big topic and can be. I want to make sure you realise what we're up, what we deal with. So musculoskeletal disorders, I suppose you're all aware of, are not really things that generally kill you, but they do affect your quality of life and well-being. And so that's the key focus of our attention. And there's a huge number of topics in this area. One of the area that we have a great deal of expertise in is musculoskeletal aging, the loss of strength and force and power in our muscles that ultimately affect our mobility and our stability and our independence. And in fact, you'll get a little a view of some of the research we're doing there in the next presentation from Matt Piasecki, who's representing that bit of work. there's also enormous amount of work going on about another major problem, which is simply musculoskeletal pain, joint pain, painful knees and hips and things like that. Again, this doesn't kill you, but it does affect your quality of life. And we have a presentation on that as well today, because these are two of our major areas that we have done research in and are researching right now. And that's from Jo Stocks, and she'll speak after Matt. But I want to give you just a list that you're not going to hear about today of all the other things that we are involved in, just to make sure that if those aren't the areas you're particularly interested in, that we do have much broader interests. So one is rheumatoid arthritis. Another is the thinning of the bones with age, which is osteoporosis. That's also musculoskeletal. Sports medicine is something you might not have thought about, but that's actually an area where there's a considerable amount of expertise and interest and value, and we do that too. And there's a lot of link between the various areas I'm talking about already. A very important and growing area is trauma, fracture, broken bones, that is, injury, and the surgery that's involved after trauma and fracture. And indeed, this will become one of the strong areas of the new research project in the research theme in the future. And aligned with this, and indeed with all these topics, is that rehabilitation and what we refer to as the recovery sciences, how not only how people are affected by injury, but how they recover from it, are also part of the areas that we research. So a very wide field of things that we are interested in. And then my second slide is simply, well, how do we do it? And we're keen really, and indeed in most research, we're keen really to use novel, innovatory research techniques, because it's only really through using new techniques that we're going to get new information, and that's what research is really all about. So it's a very wide range of research. It subtends the laboratory sciences, where we will be studying the genes that affect musculoskeletal conditions, the molecules, the tissues, the organs, the systems. All these are things we can look at in the laboratory. We have a great deal of strength with imaging, the magnetic resonance imaging in particular, that was invented here in Nottingham, and quite literally Nottingham is world leading in MRI work, and so we use those techniques to discover things that we would never have been possible to have seen even a few years ago. There's another area that is becoming very fashionable and very interested is big data, what we refer to as big data. As you're well aware now, there's data everywhere in our phones. Everything is computerized. And now we've got not only the ability to generate this data, but also to analyze this data. And it allows us to do things we've never been able to do before. And an example that we have in our group is looking at rare diseases that no one hospital or no one city would ever be able to study. But if we can bring them all together through big data, we can start to study rare diseases. And of course, we've got what we call the applied sciences, the translation of the sort of laboratory and basic and discovery science that I've been describing there, to move it out of the bench or the lab into the bedside. That's a little slogan we sometimes use. And that involves clinical trials, which many of you will be more familiar with when we think about health research. And to do all of this, the key thing that's particular about the Biomedical Research Centre, the BRC that we keep referencing, is a partnership between the university, particularly where the scientists are based, and the hospital where the patients and the clinical academics are based. And that is the basis of the success that I believe we're having in the musculoskeletal field. Now, it's only a short presentation. All I wanted to do was cover the topics and cover the way we address those topics. So I shall stop now there, because the most interesting things are to come. Have we got any questions, Kate?
No questions yet.
Good. Well, I tell you, why don't we go straight on, because no one likes to answer questions, and we'll pick them up as things get going. Let's go straight on, and we'll stop sharing and pass over to Matthew.
Thanks, John. So I'll just share my screen. So hopefully you can see that and hear me. So as John said, one of the main things we're interested in musculoskeletal health is skeletal muscle, and we can essentially divide that into two clear categories. One is muscle strength and the other is muscle control. So with respect to aging, there is a good argument that rather than trying to keep our muscles particularly strong, we should also be focusing on keeping them at a decent level of control. So when we switch a muscle on, we want it to activate, essentially. And one of the key muscle groups that we're interested in, you can see from one of our volunteers here, is the quadriceps muscle. So these are important to us because these are the ones that get us upstairs and get us out of chairs and get us out of the bath and so on. And we know to a certain extent, regardless of what we do, as we get older, these muscles will become smaller. And these are MRI scans. So this is taking a section. So if you imagine a view cut from the middle of the leg, this is the bone, the femur in the middle of the leg. And then our young participant can see there's quite a lot of muscle here. The dark area being muscle, the white area being fat. When we compare that to our older participants, we can see that the amount of muscle is much reduced and there's a greater level of fat. And they look like steaks. If you were going to buy a steak, you would probably favour this one rather than this one, simply because there is more meat on this. But in addition to that, we're also interested in the nerves that supply our muscles. So these things here. So this is an image of the spinal cord, and we have these motor nerves that travel down to our muscles and tell them when to switch on and also when to switch off. So just to display that a little bit clearly, the signals originate in our brain. Most of us don't even realize we're doing it when we're walking. It's an automatic, almost a reflex. And these signals propagate down the spine. They go to nerves and transmit to our muscles. And the common analogy for this is often a light switch. When we switch on in the brain, we want this to light up. But that's perhaps an overly simplistic view. It's actually much more complex, unsurprisingly. And it's more like a dimmer switch. These have tended to fall out of fashion a little bit over recent years, but it is a better analogy for the concept of muscle control. Rather than a switching on or off, we can switch muscles on to a high level or a low level. And to complicate it even further, not only do we have signals traveling down from the brain to the muscle, or from the light switch to the light bulb, we also have signals traveling back. So it can be quite a complex system in motor control. And the purpose of one of the studies we've just completed with the BRC was to see if this is something we can improve with training. And when we come up with a new study idea, what we tend to do is see if we can prove the mechanism or prove the model in a younger, healthy group. So for this, we took 8 people and applied 4 weeks of targeted motor control training. So we only trained one leg, and each person trained for 3 sessions per week. So it's kind of similar to visiting the gym 3 times per week. But importantly, each session was quite small, so it's quite short, so only lasting 20 minutes or so. And the muscles we trained were the quadriceps. So as I said, these are the large leg muscles important for what we refer to as activities of daily living. So common things like walking upstairs, getting out of the chair, these are where we need the control and the strength in the muscle. And also a muscle called the Tibialis Anterior, and this is in the shin, and this lifts our foot when we walk. And we find that it's reasonably common when people fall, they fall because they catch their toes when walking because of an inability to properly activate this muscle. So these are just a few images of our setup. So we This is the muscle we're interested in. This is one of our younger volunteers, the quads in the upper leg, and the tibialis anterior, so in the shin. And this muscle essentially lifts the foot and lifts the toes when we walk. And to measure these signals, these electrical signals traveling from the brain to the nerve, we can use things like electrodes on the surface of the skin, and we also use electrodes that we insert into the muscle. So this is like an acupuncture needle, but on the tip of it, it has a small recording electrode. And all this activity, all of these signals coming from your brain to your muscle, we can measure. So I've just got a little video of the actual training program. Apologies for the poor quality, but you should get the gist. So when a participant is sitting in the chair, the yellow ball that you can see, they control. So they have complete control of that, and they're asked to follow the red line. So this is at the very start before somebody's begun their training. And we can see that they're not really following that red line very well. Towards the end, they start to grasp it, but when they have to switch the muscle off and no longer contract the muscle, they really start to struggle. So bear that in mind, and we'll compare that to an image, a video of the end of the training. So there's 4 weeks of targeted motor control training. Results, does it work? That is the key question. And the answer is yes, it does. We trained one leg, and in the knee extensor, so this is the quads, the upper leg muscle, everything improved. So each one of these dots is a single person, and everybody improved. So the smaller the value here, the better the level of control. So this is how closely they can hold that target line. So everybody improved in the trained leg with no difference in the untrained leg. And if we compare that to the lower leg, the muscle in the shin, we can see the same happened again. Every single participant improved in the trained leg with no difference in the untrained leg. So the answer is yes, we can take people, we can train them to do a specific task, and we can improve their level of motor control. But in physiology, in musculoskeletal health, that's not enough. We need to understand why. So with all of these electrodes that we put inside people's muscle on the skin surface, we measured all of these signals. And this is the motor control at the end of the 4 weeks. So we find that participants actually get quite addicted to this game. They often ask if they can have another go. So again, the little yellow ball and the blue line is entirely controlled by the participant, and they have to track the red line as close as possible. So you can see as the muscle switches on and off, the force goes up and down, and that level of control is much improved. But as I said, we need mechanisms. It's not enough. We need to describe, or we need to understand what has instigated this change. And if we go back to our diagram of the brain sending signals down the spinal cord to these motor nerves, these are the electrical cables that feed into our muscles, we know that the timing variability improved in these young people. So we can link this mechanism, what is happening with these signals to generate an improvement in motor control. We know that the timing of these signals vastly improved in all of these young people. So the next thing we need to do is try it in some of our older volunteers, and we'll hopefully be starting that study over the next couple of months. And with that, I'll just have a few acknowledgements. So this is a study led by myself and Beth Phillips. But as always, Izzy was the master student on this project, and she essentially did all of the work. So I'll be happy to answer any questions you might have.
Thank you, Matthew, for a fascinating presentation and showcasing some of your research there. We haven't actually had any questions in the chat yet.
Okay.
I will repeat, no question is a silly question, so please do ask away. We have put time aside for questions, but if no one is putting any through now, we can move on to our next presenter. If you do have any questions for Matthew there, please do put them in the chat, and then we will come back to them at the end of this keynote. Oh, we've had some come through. Excellent, thank you. So firstly from Kathleen, what were the exercises that you were asking participants to do, Matthew?
Yeah, so the exercises, the purpose of it was to make it not like going to the gym. So we do what we refer to as very low intensity exercises. So these are, it's nothing like lifting weights. It's nothing like going for a run. It's simply sitting in a chair and controlling your muscle, both off and on. So the purpose of it was to design something that wasn't physically difficult or even mentally difficult. So yeah, the exercise, what we refer to as isometric exercises. So very little movement and very low intensity. So after each session, people get out of the chair and they're not tired in any way.
Thank you, Matt. Thank you. So next question from Barbara. How are you recruiting participants to the trial? How did you approach that?
So for this trial, we recruited young only. So we recruit them from the general population. A lot of our participants come from the university students. And then when we recruit older people, we tend to go out to the local community. And also events like this tend to be quite useful for recruiting participants. So we're always looking to enroll new participants. So if anybody is interested in taking part in this study, then please do get in touch.
Excellent. I like the plug that you gave.
Yeah. There are benefits. I don't know what they are, but there are benefits.
Not yet. Okay, and one more question from Deborah. Does your study look at the effect on nerves as well?
Yeah, absolutely. So that is the main effort of the study. So we can separate the neuromuscular system into muscles and nerves, and we understand quite a lot about muscles. We know if we lift heavy weights, they can get a little bit bigger and a little bit stronger. We tend to know a little bit less about nerves. So the purpose of this study is to measure these signals that come from your brain to your muscle through your nerves. So yeah, the purpose of the study is to look at nerves in particular rather than muscle alone.
Brilliant, brilliant. Thank you, Matthew. And I think your plug has worked. We've had a few people querying how.
Great. See you soon.
Brilliant. Thank you so much. And I think, Matthew, if you've got a link you could post on how to contact the team about participating or finding out more in your research. Oh, Beth has just popped that in the chat. So great minds and all that. So yes, I think we will move on now to the next presenter just to keep in time. I've noted there's been a few other questions in the chat, but please know we're monitoring the chat and we will ensure that all these are answered before the end. John, sorry, did you want to come in? No? Brilliant. Okay then. We shall move on then to our next presenter, who has kindly stepped in for Anna Valdez, who was unable to join us this evening. So we will move on to Joanna Stocks, who is going to be showcasing another research proposal for us. Oh yeah, there we go. So Joanna, I'll pass on to you if that's okay.
Sorry, I had to unmute myself.
The slides have just gone down, Joe. They were up a minute.
Yeah, sorry, I had to unmute, take them off to mute myself. So, are we back on? I'm good to be back. Right. Okay, and we're back. Okay, so thank you for inviting me to speak today. I'm going to talk about some work that has been done by my colleagues. So it's been led by Professor Anna Valdez and has primarily been undertaken by Samir Gohir, who is a PhD student and physiotherapist. And the work that they've been doing is to look at treating knee osteoarthritis through exercise using an app. And also, again, discuss how they've learned about molecules that have been involved in arthritis pain. It's not going to the next. Okay. So, as you may or may not be aware, arthritis of the knee is extremely common in people aged over 60 and is one of the major causes of disability in the world. So one of the causes of osteoarthritis is that cartilage wears down between the knees, and this can cause the joint space between the two bones to narrow, and the bones then start rubbing on each other because they can't keep a normal distance apart, and this can be really painful and also can put too much pressure on the joints. Another thing that can happen is that you can have osteophytes growing, and these are like little bony lumps which grow on the outside of bones, and this can be caused by inflammation, such as during in osteoarthritis. And again, this is another symptom that can cause painful knees, as your knees don't move smoothly and they become painful and stiff. And so at the moment, there isn't a cure for osteoarthritis. We can only deal with treating the pain. So what we're wanting to look at is how can we deal with the pain and the disability that osteoarthritis causes. So here is the most extreme treatment. This is the last resort. If you've got severe osteoarthritis, then we have total knee replacement. And as you can see by the pictures here, they're quite invasive, and as you can imagine, that needs a long time in rehabilitation after you've had this surgery. So this is our last resort, and we want to try and find alternative treatments before we get to this stage. So one of the treatments we could look at is education. So actually learning for the patients to learn how to cope with the disease. So I've just been involved in a study last year, and we looked at around 6,000 people in the community. So it was called Knee Pain in the Community study, and questionnaires were sent out, and over 6,000 people responded. And we asked them what did they perceive was the most effective treatment that they had tried for their knee osteoarthritis. And 26%, so over 1 in 4 of people, said that exercise was the most effective in treating their pain or helping them cope with their pain. And then when we asked them what was the greatest factor which caused or had the greatest influence on them trying exercise, it was their healthcare professional or a physio recommending it to them. So this should be something that's advised by the physios, because the patients find it very useful, but also they need the recommendation from their physio or their healthcare provider, which is also good that they actually take the recommendations from a qualified professional as opposed to Dr. Google. Another treatment option is weight loss. So yes, we all know that we need to lose weight for lots of reasons, for diabetes and cardiometabolic health, and also the weight bearing, so the excess weight can impact on your joints. But we also know that it's very difficult to lose weight, and if you're on lots of pain medication, that can also help you or hinder you in your weight loss. So it is, whilst we know we need to lose weight, it's hard to actually advise people that this is a treatment option for their osteoarthritis. Other options are paracetamol or ibuprofen. If you've got severe pain, this isn't very effective, and there's also some side effects. And then we have other prescription painkillers, such as opioids, and here we've got some risk of serious side effects and addiction. So again, it's not something that we want to recommend. So the option that we're looking at in this study was to look at exercise as a treatment for osteoarthritis pain. And the exercises that were chosen were to look at strengthening muscles and relieving your pain and seeing whether they were safe and effective. And the thing that we wanted to do was to see how can we motivate people to keep doing this exercise program several times per week. So have we got us here? This is another study that's shown that exercise is one of the safest and most effective ways of dealing with osteoarthritis pain of the knee. So if you look at the effect size, so a moderate effect size is any value over 0.5, and this is seen as a clinically significant effect, so it actually would make a clinical difference to a patient. It's not just a random number, actually would have an effect on them and the amount of pain that they're experiencing. And you can see that exercise not only improves the function of the patient, but also their pain levels. And it is even better than prescription medications. So this study actually was set up 2 years ago before COVID. And I think that we've all seen that with COVID-19, it's highlighted the importance of having some sort of virtual or digital based health delivery. People haven't been able to go to see their healthcare providers face to face, but actually we're doing a lot more online or using apps on your phones. So what the questions the researchers wanted to ask were, are exercises effective if you deliver them via an app as opposed to face seeing a physio? How does the exercise app compare to the usual treatment that they get from a GP? Will they improve the people's pain and their ability to walk? And can we find out about things that make the pain worse? So they used an app called the Joint Academy app. And this is an app that's currently used in Sweden and was developed through face-to-face visits with over 70,000 patients. And then they adapted the program that they developed and devised videos and take the patient step by step through the exercises. So if you can see the pictures on the left-hand side, there's people doing it at home. They don't need any special equipment. They don't feel intimidated going to a gym or doing the exercises in front of other people. And it's all really accessible. The other thing that they do is that you track or you monitor the exercises that you've been doing, and then there'll be a physio who you can speak to, who you can ask questions, and they're depending on whether you say that the exercise was easy or difficult or you were feeling sore the next day, then the app will adapt your exercises that you need to do the following day. So just going to go back into this. So the other thing that was useful about this app is that you got reminders. So every day you get an email, you get text alerts to say you haven't done your exercises today, and it was motivating people to do their exercises, as opposed to the usual care where you perhaps get given some exercises by a physio 1 week and a piece of paper, and then to come back in 4 weeks' time, and you haven't got that daily motivation reminders from somebody. So the study is called iBeat, which is internet-based exercises aimed at treating knee osteoarthritis. And initially 140 people with knee osteoarthritis recruited. And we also took bloods and fecal samples to do some other tests that we talk about later. So at the start of the study, we measured their pain sensitivity, and their ability to walk and get up and down from a chair, and also their muscle strength. And then for 6 weeks, they were either given exercises through a piece of paper advised by the physio, or they were given access to the app. So it could be an Apple phone or an Android phone. There's two different apps that you could use. And then after 6 weeks, they were followed up. So unfortunately, COVID happened in March 2020, and not all the participants were able to be followed up. So there were 13 and 14 people in the respective groups who they couldn't get the full data from. So we had 57 in the control group and 48 in the exercise group. who were able to complete the full 6 weeks. So we also collected blood and fecal samples from the participants, and from the blood we measure substances in the blood and test whether they are related to levels of pain and how well people respond to exercise. And we also measured the gene expression to see whether we can relate the substances that we found in the blood to the pain that they reported. And in the fecal samples, we measured participants' gut microbes and test how they relate to pain and anxiety and how people perceive pain. So what did we learn from the samples that people donated? So we found that we can predict in the blood if a person will have higher or lower levels of pain, or if they respond to exercise, as a method to reduce pain. And we also repeated these experiments in mice with osteoarthritis. And we tested which genes are related to high levels of those molecules. And we found that some gut microbes are involved in higher levels of pain and anxiety. So did the app work? So this is called a numerical rating scale, and we asked people to score on a scale of 1 to 10, with 10 being the worst pain possibly imaginable. How is your pain at the moment? And if you see, after 6 weeks, the group that used the exercise app, which is the red line with the red triangle, they had less pain than the control group, which is the blue line with the blue circle. So we say that if the scale is below, if it decreases by 2, then that's a clinically significant difference. So as you can see, there was a clinical significant difference in the digital health group compared to the control group in the amount of pain that the patients were experiencing. They also looked at the timed get up and go test. And here you have to get up out of a chair, not using your hands to help push you up. Then you have to walk around for 3 meters and then walk back to the chair and sit down again at your normal pace. It's not a race. And if you look at, again, the control group, the blue line, we found that there was no difference in their walking speed, whereas the digital program group, their timed up and go test was faster. Also looked at the amount of time that people could stand up in 30 seconds from a chair. So you see the image on the left-hand side, the patient's got their arms crossed over their chest, and they have to stand up. And again, the control group participants didn't really improve, whereas there was quite a big increase from around 9 to 14 chair stands per 30 seconds in the exercise group, and they had significant improvements in the strength of their leg muscles. So from this study, we learned that actually using an app is an effective way for people to manage pain with osteoarthritis. It improves their muscle strength of their hamstrings and their quadriceps. It improved their functional abilities, so walking and getting up from a chair, and also improves their self-satisfaction of patients with their activities in daily living. And also there's an improvement in the functional ability, which is correlated with improved leg muscle strength. And we're still analysing the molecules in the samples that were donated by the participants, so we can generate more knowledge from the blood and the fecal samples and how this correlates with osteoarthritis pain. Thank you very much.
Oh, brilliant. Thank you so much, Jo. And thank you for stepping in at short notice as well to present that. It's a fascinating study. And I have had one question from an attendee already. So I'll pose that one first while we wait to see if we get any more questions come through in the chat. So they have posed, what factors do you think were associated with the internet-based program being more beneficial for these patients?
I think that they seem to like the interaction from the healthcare provider. So the physios would be contacting them a couple of times a week. They were getting the daily reminders, and I think just the interaction and the personal the personal interaction with people makes them feel involved as well, that they're not being forgotten about. I think sometimes perhaps if you're just given a piece of paper, you feel like you're not having the treatment, and you're being forgotten about. So I think that was the benefit, that they could see if they were improving, that their treatment recommendation that they're being prescribed was told to increase the level of exercise they had to do, or if they weren't doing so well, then they would reduce it down. So I think that sort of personalisation of their prescribed treatment, I think that was the thing that was very beneficial.
Thank you, Jo. That's really interesting. Okay, the second question we've had is, do you think that the internet-based app would be suitable for all patients with knee osteoarthritis?
So this study was for people who had what we call a KL grade of 1 or above. So this would include people who had very early stages of osteoarthritis. So they might, like I said, describing the osteophytes, the little bony growths, they might just be having a few of those now, but perhaps the radiographic array, so if we could identify it using an X-ray, they would just be getting some symptoms that you'd be able to notice. So we did look at people that had early OA, maybe people who are on a grade 4 and very severe and were ready to have knee replacement surgery. Maybe it wouldn't be as suitable for them. There's no reason why they shouldn't try it, but yeah, I think it would be worth redoing the study again, and hopefully with more people that don't get interrupted due to COVID, and we would be able to separate out the groups and do some analysis whether if you had early OA, you responded better than people who had more severe symptoms.
Thank you, Jo. Yeah, and we've got one more question from Kathleen, who has asked, are you sharing this study outcomes with GPs and other community professionals?
So the paper has actually only just been published. I'm going to check when it is. It was in March this year, which is JAMA Network Open, and it was the first author is Samir Gohir, if you want to look it up. But yes, it will be disseminating the data or disseminating the findings at peer conferences and things like that.
Lovely, thank you so much, Jo. Oh, we've had one more question. We can try and sneak in before I pass back over to John. So one more, Jo, if that's okay. Do you think that the same principles would apply to arthritis or in any other joints? So the same principles of the study. Do you think that would be the same outcomes might be found?
I think so. I think that was the idea, that the fact that if personalising your treatment, getting the daily reminders, having the access to a physio when you needed to ask a question, if you wasn't quite sure how to do an exercise, you could go and ask somebody, or remind if you're doing it right or wrong. And I think just that reassurance that if something wasn't working or you felt you was in pain, you could actually speak to someone, not have to wait 2 weeks later for your next appointment. I think that's the sort of thing that benefits. So yeah, I think it would be worth considering for conditions.
Really, really interesting. Thank you, Jo. Thank you so much again as well for stepping in. And thank you, Matthew, as well, both of you, for sharing those kind of showcases, those good examples of some of the research that's being conducted within the theme. If anyone has any more questions that you think of, then please do pop them in the chat and we'll be able to respond to them directly there. Now I'm going to pass back over to Professor John Gladman, who is going to give an overview of the patient and public involvement strategy for the musculoskeletal theme of the Biomedical Research Centre. So John, I will pass back over to yourself, if that's okay.
Are we sharing?
It's just not full screen, John, if you want to.
I'll just go back to it again and no, it's the wrong one.
That's it. Yeah, perfect.
Right. Okay. Well, thank you very much, both of the speakers. I have to say, I think we could spend the whole time in this session just talking about the research, and you know, a bit that blew me away is the thought that there is something in your feces that might tell you whether you're going to respond to exercise, or something in your genes that will tell you about the control of your pain, and that opens up astonishing opportunities for completely new ways to look at pain. So behind this useful and simple study was some really clever science which is going to come as well. But what I've got to talk about today is a little bit about really our public patient and public involvement strategy and the plans, and in particular what help we would want from you now in developing this. And that's where the breakout rooms are going to come in a few moments' time. So I don't want to do a little bit of background, and without my first point is a pretty simple one, that patient and public involvement is a good thing. I think we all agreed. We wouldn't be here if we didn't agree that. I'm not going to go through the case of why it is. I can also say that in our musculoskeletal, our MSK area, there's actually already quite a number of well-developed groups. For example, from the Pain Centre, for example, a group that Kate Sarton, who answered the last question, is involved in dementia and frailty. There's sports medicines one. There's a big group based in the group with Bethan and Matt over in Derby. So it's not as if we have to start from scratch here. We have some well-developed groups, and we have many, at least pockets of experience in the research team. People like Joe Stocks, who's just spoken, is really well experienced and gets this and has been doing it for a very long period of time. So we're not starting from scratch. But the questions we need to ask about is how we do it better. So if the mission was what we do now, which I've described, and if the vision is what we aspire to, then our strategy is how do we get from the mission to the vision, from where we are to where we want to be. So the vision, I've written something, it's a little bit long, it's a little bit wordy, but the key points I want to draw out here is that we're all about just maximizing the scientific quality of research. We know that the research is better if we have patient and public involvement. That's just, and we want to do the best research we can. So of all stages in the research, we need the assistance of patient and public. And furthermore, this is not now just a thing that we're inventing. This is an area that has got a lot of thought about it, particularly in the UK. We're somewhat world leaders in this. And 6 standards have been set, as I've described here, about where we need to be concentrating in order to get the maximum out of patient and public involvement, being inclusive, collaborating, training people to do the job, having good governance and systems to make sure we do it well, communicating well so that we show our findings and share them and drive them towards impact and making a difference in the real world. So that's around being proactive. I use the word proactive. Engage with wider public, not just a smaller range of people. We've got to talk about with other stakeholders, not just patients and the public, but other people who might be relevant, like, you know, the matrons who run care homes, or people who organize exercise classes, or sports people. These can all be stakeholders we need to deal with. And we need to be thinking not just about talking about the research, but really a very broad picture. What are the ethical consequences or implications, or the social or organizational implications of our research. And that's terribly important, because as researchers, we can easily get interested in the very specific results of our studies without really thinking about their implications. Patients and public can help us to keep a better vision on that. So how do we get there? That's a fairly grand ambition. And what I've got down is just a few steps, which I'd like comments upon, of just what we can do better that might take us that way. And one thing that's pretty blooming obvious to me is that we actually need to have a formal system for doing this, and a budget. So it's something that's not ad hoc, something that's not just an add-on or a tokenistic thing that's done when the rest of the work is completed. Now, this has to be core and controlled and organized and managed. And furthermore, we think that whatever we should do with patient and public involvement should link to our communication strategy, to our staff development strategy, and other core strategies of how we do the best possible research we can. Because we have existing groups, as I've said, we don't need to invent them, but we do need to consult with people. And a particular value that the Biomedical Research Centre can do is by sharing between these groups, we can perhaps add value, sharing resources, experiences, training, and so on. We also need more events like this, whether they're virtual like this one, face-to-face, or blended. We need to showcase. We've got plenty more to showcase. I'd love to show you stuff from our MRI studies. And then we want to have conversations about these research ideas and how we share them and how we get them out to the people who need to know them. So we can only do that if we have regular events and these conversations. I mentioned about sharing expertise and so on. And one of the things that that we have available is a thing called the Share Bank, which is a kind of repository of an enormous number of different training opportunities and learning opportunities designed specifically for patient and public involvement. And that's something that we hope to be able to spread and share and use more widely, so that as many people as might benefit from that as possible are found. We've got something rather more specific that I think we need to have put into our plans, and that's basically to make sure that patient-public involvement and engagement are not optional extras, they're not tokenistic, and that anything that we support in the MSK theme or and badged under our banner needs to have formal plans that we actually agree and are signed off, and that we ensure are delivered. That's something you might think should be there already, but it's not, and we want to make it so. And there's another area that we think is very important. This is particularly around training our research staff, which is training our staff in knowing how to work with patients and the public and get the best out of it. And so we want to promote a PPI buddy scheme for all our PhD students, and make that a sort of, without being too hard about it, a mandatory thing that it's expected in all students. If they're going to be excellent researchers, they need to be excellent in PPI. And there's a final thing that I put on the list for the strategy, and that's about improving the diversity of the approach. It's a general criticism of many patient and public involvement organizations and systems that they tend to be overrepresented with basically white educated middle class people. And I've got nothing against white educated middle class people, but there's always a concern that we really ought to have an even greater diversity, particularly of the populations that are affected by musculoskeletal conditions, and they're not always white middle class educated people. And that's a real struggle to increase diversity. And to some extent, that's the whole plan of the next session, which is around these breakout breakout rooms, which is to have these more open conversations around issues about how we develop this strategy. And we've planned them with rather loose titles. It doesn't really matter which ones you go to be honest. But if there's something that you'd really like us to do for you, then maybe what would you like from us is the one that we'd like you to drop into. If, on the other hand, there's something you're really burning to tell us or offer us, a resource or something that you think we really ought to know, then please go to the what would you like to offer one, and we'd very much like to listen to that. On the other hand, you may have been interested in my mention of the PhD buddy scheme. You might be wanting to hear a little bit more about that, or even potentially consider volunteering for that, thinking it might be fun. And there's a breakout room to discuss that. Similarly, there may be people in this room here who have quite a lot of knowledge and expertise about addressing diversity, and we could learn very much from your experience, which you may have dealt with in other areas, not just in research. But I know people on these sorts of meetings have enormous amount of experience that we academics don't have. And then the final one is there may be particular topics or areas that you really want us to work research into that I haven't mentioned, or you want to check that we're mentioning, and maybe ones that ought to be part of our future research programs or research plans. And so if there's something, a topic, for example, that you're really burning or want us to ask us whether we can research, then areas of research, areas of interest is the one for you. So we're going to invite you to go into those rooms, have a conversation, just chat about these things for 20 minutes or so, or slightly less, and then we come back and try and wrap up. But we would like to, as I say, start the conversation going in those breakout rooms. I'm going to pass over to Kate to tell you a little bit more instructions about exactly what we do now.
Lovely. Thank you so much, John. And I hope that everyone in attendance is feeling inspired, ready to go into the breakout rooms and have some really insightful discussions about the strategy that John has just laid out and the future of patient and public involvement in shaping that. And this is really what this event is all about. It is hearing from yourselves and what is most important to you, because we really do want to shape that with everyone. So thank you again, John, for that summary of the session. So what we're going to do now is invite you to join one of the 5 breakout rooms that we have on offer today. If you move to the left-hand side of your screen, you should see a panel that pops out, and you will be able to see breakout rooms listed A to E. These are in order of what John has just presented on the slide. So in a moment, John, I'll ask you to reshare that last slide, if that's okay, so people can see which breakout room is associated to which topic of discussion. You can also see this if you go to the lobby and click on schedule. The themes of the breakout rooms are also listed in there. We will have people facilitating these breakout rooms, but we will not be recording these sessions. So please do feel free to have those open, honest and transparent discussions once you are in there. We have run a little bit over, so what I'm tempted to do is still give us the full 25 minutes in these breakout rooms. So what I will do is notify everyone 5 minutes before and when, and we'll be coming back to the keynote for our final wrap-up thank you and next steps for the event. So if that's okay, John, if you could quickly, yeah, brilliant, share those slides. So what you would like to hear from us is breakout room A. What would you like to offer? The musculoskeletal theme is breakout B. The patient and public involvement buddy scheme is breakout room C. How we increase our diversity and inclusivity is breakout room D. And then breakout room E is any questions that are unanswered. So what areas should we be focusing on in musculoskeletal research? And that is breakout room E. Again, if you want to be reminded of which breakout room is which, please go to the lobby where you'll see the schedule of events. I'll leave you there. If you'd like to take a comfort break before making your way over to the breakout rooms, please do. And again, these are informal conversations. So mantra again, no question is a silly question. So thank you very much, everyone. And we'll see you back here at 7:25.